Hey guys, Dr. Linville here. Welcome back from your 2-week break from this class. Thank you guys so much for allowing me to take a week off for my wedding. I know I very much appreciate it, so did my wife and my family who was in town from across the country, so thank you. Also, I hope this week has gone very well for you in your studies. I know you had that big practical, so would love to hear about how that's going. And as you move forward in your career, I hope this week, giving you this week off and the recorded lecture, has really helped catapult you to being a great clinician. So, without further ado, let's get into the spine postoperative considerations. So, just as a quick side note, this lecture, there's going to be a lot of review from our Musculoskeletal 3 class. That lecture at that time was very in-depth, and a lot of the stuff I'll just be expanding on in this one. So if you see some slides that look familiar, that's fine. I just want to make sure we clear up some special things and dive a little deeper into the knowledge and the surgical interventions behind some of these things, as well as the big push now for Get PT First. The spine is one of those areas that we're starting to think that surgery is really not a good idea. And we'll get into that later in this lecture, but just as a review, the spine is beautiful in its complexity. You can see the anatomical structures here and how they all interact. The spine is literally the core of your body, and it is much more structurally sound than people give it credit for. Right? You meet someone with back pain and they think that their back is very brittle and very weak and that sort of thing. That's not true. There's probably just a miscommunication between their pain signaling and things like that, where they're in a tremendous amount of pain and they have all these yellow flags and even maybe blue flags, if you remember back to that. But we will dive into all that as we go. Structurally speaking, the spine is very, very strong and something that you should always educate your patients on. So again, reviewing spinal anatomy. If you guys don't know this at this point, we're in big trouble. I wish you luck if you don't know the segments of the spine, but PT might not be the career for you. But because that's not the case, let's just review it quickly. You obviously have your cervical, thoracic, lumbar, sacral, and I guess you call it the coccyx as part of your spinal segments, right? The big problems that happen here is at the levels where you see the color changes. So at the CT junction, the TL junction, and really at that sacral, that lumbosacral junction as well. Those are the areas where some of the most problems happen, especially when it comes to structural abnormality. The other part is between the upper C-spine and the lower C-spine. So some people classify that as C1, C2 as the upper, and then everything below would be the lower. We also see some people with poor posture, that usually that middle C-spine or that C3, C4 can cause problems based on the relative stress between C4 and C5. So there's kind of an upper, a middle, and a lower C-spine, and anywhere in between those segments is usually where we see some problems. But I just want to point out the importance of the curves of the spine. So lordotic curves, you see those in the cervical and lumbar, kyphotic curves, the thoracic and sacral, and then don't forget about your scoliotic curves, which typically happen in thoracic and lumbar, and that's going to be important, especially in treating thoracic patients rather. And the most common is a right side C curve of the thoracic spine. But as we move on to this next slide here, actually I think it's the one after this, but we'll talk a little bit more in depth about why the lordotic curve seems to be the one that causes the most problems. So again, reviewing anatomy of the vertebrae, you have your lamina here. We're going over this just because this is where these are commonly operated areas during surgery, the spine's processes, and of course the facet joints. So if you need to pause and review the anatomy, please do so, but we'll move on. So spinal surgery typically consists of two common procedures, a decompression and a fusion. And as their name implies, a decompression is removing pressure from an area. Fusion is trying to better the structural integrity of bone, right? So you're fusing segments together to create structural stability. Lordotic curves, as I just mentioned, These are the areas, the cervical and lumbar spine, are the most operated areas of the spine. Increased lordosis, right? So increased stress into lordosis, hyperlordosis, leads to stress on all those structural components, can lead to things such as spondylosis, which is essentially just degeneration or arthritis, spondylolysis, and of course we have our spondylolisthesis or our anterolisthesis, where relatively speaking, a vertebral body slips forward on the one below it. So that can lead to some pretty bad problems, and we'll talk about that in the fusion section. More review from MSK3. When we talk about decompression, you need to know your medical terminology. The biggest things you'll read on like post-op scripts and stuff is ectomies and otomies. So ectomy, suffix, means removal of something, right? And otomy means the cutting into of. So think of like lobotomy, where they cut your frontal lobe. I'm sure a lot of you guys in your career as PT students feel like you've had a lobotomy, but I assure you have not. So keep working hard. But ectomy and otomy, those two things are going to be really crucial in knowing understanding those, so you know what surgery occurred. So the big things here, and I'll try to move this little guy out of the way, is your discectomy. That's removal of part of the intervertebral disc to relieve pressure on the spinal cord or nerve roots. Your laminectomy, so removal of the lamina. It removes the back of one or more of the vertebrae, usually to give access to the spinal cord or to relieve pressure on the nerves. A laminotomy, which is when they just cut through the lamina, removes part of the lamina of the vertebral arch in order to decompress the corresponding spinal cord and our nerve root. A facetectomy, traditional open back surgery designed to remove a portion of spine growth that results from facet disease and has impacted a nerve root in the spinal cord, or spinal canal rather. So this is actually what we would consider like an osteophyte. They would remove that. And then a foraminotomy or foraminectomy, performed to expand the openings for the nerve roots to exit the spinal cord by removing some bone and other tissue. A foraminectomy generally refers to a procedure that removes a large amount of bone and tissue. So as we continue going here, you guys need to know those and the definitions of each. Here is just a visual, and these slides are very familiar to you guys from MSK3, so we won't spend a lot of time, but I encourage you to pause the video and then look and see, structurally speaking, what we're talking about here. This is also similar, your discectomy and your facetectomy. You can pause it here if you'd like. And then finally your foraminotomy on the left. And what we didn't go over earlier, but we did last term, was a corpectomy, which is a disc removal. And usually they'll put a spacer in, as you can see there, or a bone graft that creates kind of this fusion. They don't typically do a corpectomy. They won't do it unless they're doing a fusion as well. So that kind of comes with the territory of a fusion. So if you need to take a break, you can pause it here, but we're going to go more into the cervical spine, surgical procedures and post-op considerations. We'll look at cervical decompression and anterior cervical discectomy and fusion surgery. You'll see how it's spelled there, discectomy with a K. You'll see it written either with a K or a C, same thing. So ACDF, anterior cervical discectomy and fusion. Cervical spondylosis or degeneration presents as different clinical syndromes, with the most common being degenerative disc disease, radiculopathy, and myelopathy, all of these of the cervical spine. Cervical degenerative disc disease may present as axial neck pain, neck stiffness, or headaches. So just right there, before we even talk about surgery, those three things we can certainly impact. We can improve a patient's pain tolerance. We can improve or we can decrease their neck stiffness, right, or improve their range of motion, their tissue extensibility and all that. And then physical therapists are starting to do a lot of treatments on headaches. There's, concepts. As a student, I knew this was confusing for me, but there's a lot of referred pain from the cervical spine to the head. So as you guys continue your career, if you're interested in the land of headaches, cervicogenic headaches are a big one, trigeminal neuralgia, All these things contribute to headaches that we can make a big impact on and hopefully prevent someone from getting surgery. But as we continue going here, symptoms of cervical spine pathologies, at least the big guns here, the ones that we're concerned about, are degenerative disc disease. We would call this arthritis, right? We believe this is a normal part of aging, and we believe exercise and movement can help this tremendously. And some people don't give it a shot. But things we mentioned earlier, axial neck pain, neck stiffness, and headaches. Radiculopathy, as you guys know, is upper extremity pain referred down from the neck. You have sensory or motor deficits or both in the upper extremity, usually along a myotomal or dermatomal pattern. And it's classically caused by disc herniation or osteophyte formation that's impinging or closing off the nerve roots as they exit the spinal cord. So as we continue here, myelopathy would be the most severe. It's severe disc generation, disc herniation, or osteophyte formation impinging on the spinal cord itself. So the big difference between radiculopathy and myelopathy, just one of the big differences is that radiculopathy is usually when the nerve root's affected. Myelopathy is typically when the spinal cord itself is affected. So symptoms include, but are not limited to, gait abnormalities, hand clumsiness, upper motor neuron signs, so your Hoffman and Babinski test, you're hyper-reflexive, you have motor weakness, and muscle wasting. So if those things are present, you may be a candidate for anterior cervical discectomy and fusion, and I almost said cervical, so anterior cervical discectomy and fusion, and you may hear that in some continuing education courses that the cervical spine referred to as cervical. Kind of weird to hear. We never said it that way, but it's to distinguish the cervical spine from, or I guess the cervical spine from the cervix. We're talking about reproductive systems and things like that. So especially in other English-speaking countries like Great Britain and Australia, they'll say cervical spine. Just a side note. So as we continue here, surgical indications for an ACDF. The majority of patients with axial neck pain experience eventual resolution without surgical interventions. This is aka hashtag get PT first. So really educate your patients here. Following conservative treatment, meaning physical therapy, pharmacological interventions, injections, surgery may be indicated. There is a strong indication for ACDF with progressive cervical myelopathy. So if you were to ask me, would I ever get neck surgery, the immediate statement would be, hell no. But as we continue on here, if I had cervical myelopathy, it'd be a resounding hell yes. Because, if my spinal cord's getting impinged, I would want that to be essentially decompressed. So there is times where surgery is indicated. I don't want you guys to think that surgery is always a bad thing, but most of the time, we should try to avoid it as much as possible. Relative indications for ACDF: radiculopathy that has failed to respond to conservative treatment of at least 6 weeks, recurrent radiculopathy, so radicular pain that waxes and wanings maybe over the course of like a year, progressive neurological deficit, and also severe incapacitating axial neck pain that fails to respond to prolonged course of conservative treatment, with consistent examination and diagnostic studies confirming cervical disc disease. So, some of these patients that have such bad osteoarthritis in the neck and they've lost such disc height where their spine has become very, very stiff, that may be an indication as well for ACDF. So, guys, please look over these strong and relative indications. It would be a good test question as you continue on here. So let's continue. The procedure itself, you can see in the top right that picture of the patient, that illustration of laying down. There's some retractors separating the skin of the neck. That actually looks more of like a vertical incision, but really there's a transverse or almost a diagonal incision made through the neck, the skin of the neck, and then it's dissected down to the appropriate level and it revealing the paravertebral musculature right above. So if you're thinking about from an AP point of view, you go through the neck anterior, you got to get through a bunch of structures, you finally get to the front side of the spine. So at that point there are paravertebral musculature, including some deep neck flexors like the longus colli, and those muscles are dissected off. So I highlighted that here because I want you guys to know that, because a big part of the rehabilitation process for anyone with a cervical fusion is going to be strengthening to the deep neck flexor musculature. As you can see on the picture on the bottom right, an operating microscope is brought into the field for completion of the anterior discectomy and fusion, and they do this. It's just a microscope. It's a huge, powerful microscope that gives them a great point of view, and you'll see this in the surgical videos. So what about outcomes? Postoperatively, patients with severe radicular pain will often note immediate relief of pain and upper extremity symptoms. There's excellent clinical results in this patient group, 90% and greater satisfactory results. So remember, that's with severe radicular pain. It's not with mild or moderate. It's also you can say that's good or excellent results with myelopathy. One concern is overactivity before full fusion has been achieved. So we're talking about postoperatively now. Overactivity is a huge problem, and you can actually ruin your fusion surgery. So solid consolidation, that's a tongue twister, solid consolidation of fusion often requires 6 to 12 weeks. So excessive motion and loading of the C spine are strongly discouraged. Strongly discouraged. Future research is looking into is now being done on disc replacements rather than fusion. So they're trying to create almost these prosthetics that act as your disc, so that it may allow for more normalized osteo and arthrokinematics of the neck, and hopefully allow people to move better and move longer. Postoperative considerations. The cervical fusions we talked about earlier is not fully healed right away, and actually studies are showing that until 6 to 9 months it's not completely fused. So all progressions between month 3 and 6 are done with caution and good decision making. Really all, from 0 to 6 months, that's the case. So full activity status and resuming of full activity at 6 months post-op with physician approval. The rehab program looks something like this. After 6 months, you can return to sports, again with physician approval. I would say also with physical therapist approval. You have different indications with multi-level fusions versus single-level fusions. We'll talk about that in a little bit here. Progressive weight training can be resumed at 6 months as long as you're not having axial loading through the spine. All aerobic activities are fine. Full cervical active range of motion can be completed at this time, and as long as it's pain-free. You can get a better sense here of a initial post-op patient on the top right, how it looks right out of surgery, and then the scar, probably a year or two out, where it's kind of become more normalized in color on that picture. We're not going to dive too deep into this, but this is a big surgery as well with the neck, as a posterior fusion. So just another way to attack the same beast, to stabilize the spine. This is typically due to excess anterolisthesis of the cervical spine, so we're having one segment move on forward on the other, creating spinal cord compression, and so they go in and posteriorly and they try to pull back that segment to more normalize the spinal canal. Anterolisthesis can lead to radiculopathy and when severe myelopathy, so this procedure is done for a lot of people. Surgical videos, I encourage you now to pause this and click on the videos. They should be pretty short. I don't think they're over 10 minutes long, and you can also fast forward through some of it if you need to. But I just want you to get a good idea and a visual of what we're talking about with these surgeries so that you can convey that back to your patients if indicated. So I hope you enjoyed those videos. You weren't eating anything while you were watching them. So now we'll talk about return to sport after a cervical fusion. There is an absolute contraindication after a C1, C2 cervical fusion. That should go without saying. And actually, there's a lot of patients who, I should say a lot of athletes, whose careers are ended because they have congenital malformation of these segments. And, they have congenital laxity that's not even seen until maybe they get a concussion or something like that, severe enough where they get imaging of their C-spine. So, there's a lot of people out there that probably are never diagnosed with a C1, C2 problem. So you can never be too cautious. Now, if this area has to be fused, you're going to lose a ton of rotation of your head. And really your life's going to be very, very much affected. Your quality of life will probably decrease, but the reason you would get a C1, C2 fusion is typically due to a trauma, right? So a pretty severe motor vehicle accident or falling from a very high height or getting, landing on the bottom of a empty pool or something like that. I don't know. So just pretty tragic stuff if you got to get C1, C2 fused. So as we move on here, a healed, stable, 2-level anterior or posterior subaxial cervical fusion with or without instrumentation is a relative contraindication to sport. And when it comes to pro athletes here, it's really up to the pro athletes to decide if they want to get back because this is their occupation. Now they can get consultation from their medical staff, but Peyton Manning is one of these, right? So a 1-level fusion would be like C3 and C4. A 2-level fusion would be C3, C4, C5 all fused. So Peyton Manning has a 2-level fusion. Not very, not recommended, okay? If you get over a 2-level fusion, like totally contraindicated. So there is no contraindication after an anterior single-level cervical fusion. So we're talking about, a C3, C4, for example. You can get back after something like that. But again, multi-level relative, and then more than 3 levels that are fused together, like absolute. There's no return after 3-level cervical spine fusion, no contraindication in contact sports following discectomy, and interbody fusion for lateral or central herniations in athletes who have solid fusion and are asymptomatic and neurologically intact with full pain-free range of motion. So, ACDF rehabilitation. At the initial evaluation, you'll typically see this patient at 6 weeks post-op. You want to inspect their incision site. They may even come to you wearing a cervical collar, right? It could be a hard collar or a soft collar, but the surgeons usually tell the patients to wear the collar from 0 to 6 weeks, and then when they come to physical therapy, of course, they can remove the collar and we can start doing some things. The big thing at the initial evaluation is patient education, and the reason is because there's still a lot of restrictions with these patients. You want to educate them on no excessive cervical spine, active range of motion, really, or passive range of motion, right? You don't want them stretching at end range within that first 12 weeks. And that's to maintain the integrity of the screws and the fusion itself. They're going to have no lifting arms overhead and no lifting greater than 5 pounds. So, you think about what can these patients do. We're going to do a lot of deep neck flexor training. We're going to do active range of motion of the arms. We're going to do scapular stuff. We're going to do light upper extremity weight-bearing stuff. Those sorts of things are going to be fine, but you want to maintain these precautions. Some surgeons differ in their precautions, but usually at 12 weeks you can begin progressing out of these precautions into normal functional levels, and at that 12-week mark they'll see the surgeon again and they'll get evidence of a fusion or not, right? So you'll typically get a good idea of how your patients are doing. As we move into thoracic spine, if you refer back to your musculoskeletal 3 lecture, we talked about fusions for scoliosis, kyphoplasties, and vertebroplasties. Well, there's been a lot of emerging evidence on maybe kyphoplasties and vertebroplasties are actually not really ever indicated. they're not being shown to, there's no good evidence showing that they're necessary. So let's just get into this a little bit. So thoracic spine fusion, very similar to both cervical and lumbar fusion. This is done, they obviously have to go through the back. There's no anterior thoracic fusion. So indications are scoliosis, severe scoliosis, instability, fractures, traumas, etc. You do not want this done to you. Please, avoid this at all costs and try exercise first. Your scoliotic patients can benefit a lot from exercise, so we need to educate them, and we need to put them on a proper treatment plan. So procedure, the surgery involves removal of part of all the lamina. I'm not going to go over the procedure with you of a fusion because we're going to talk about more of this in the lumbar sections. They're very similar surgeries here. So we continue. Vertebroplasty and kyphoplasty, just reviews here. Indications for these procedures is a vertebral compression fracture. A vertebroplasty, bone cement is injected through a small hole in the skin percutaneously into a fractured vertebrae with the goal of relieving back pain caused by the vertebral compression fracture. A kyphoplasty, on the other hand, includes the use of a small balloon that is inflated in the vertebral body to create a void within the cancellous bone prior to cement delivery. Once the void is created, the procedure continues in a similar manner as a vertebroplasty, but the bone cement is typically delivered directly into the newly created void. So the difference here is that a vertebroplasty, they just cement the fragments back together. The kyphoplasty, they try to give back the patient more vertebral body height and then cement that so that it's more normalized to their anatomy. And here are some pictures of that. So on the left, you'll see the vertebroplasty. On the right, you'll see the kyphoplasty. So vertebroplasty and kyphoplasty, what does the research say? In the New England Journal of Medicine, Dr. David Calmes and his colleagues had a study. It's called a randomized trial of vertebroplasty for osteoporotic spinal fractures. It's a multi-center trial. They had 131 patients who had 1 to 3 painful osteoporotic vertebral compression fractures undergo either a vertebroplasty or a simulated procedure without cement, which would be their control group. So both got a procedure, but one was just a fake procedure, essentially. The primary outcomes were the Roland-Morris Disability Questionnaire. That's a 24-question survey that basically states a lot of activities of daily living and things like that, and you mark yes or no whether you have pain with those activities. So 24-question Roland-Morris Disability Questionnaire. Also, another outcome was the patient's rating of average pain on a VAS scale, so VAS, right, 0 to 10 pain. Results: 68 vertebroplasties were performed and 63 simulated procedures. Baseline characteristics were similar in the two groups, meaning their demographics. At 1 month, there's no significant difference between the vertebroplasty group and the control group in either the outcome measure or their pain. So you can see the big difference in p-values there. Both groups had immediate improvement in disability and pain scores after the intervention. Although the two groups did not differ significantly on any secondary outcome measure at 1 month, there was a trend toward a higher rate of clinically meaningful improvement in pain in the vertebroplasty group. So it would make sense if the fragments are stabilized, but still not clinically significant decrease, p equals 0.06. At 3 months, there's a higher crossover rate in the control group than in the vertebroplasty group. 51% versus 13%, and that was significant. There was one serious adverse event in each group. So what the crossover rate means is that at 3 months, they let these patients decide if, knowing that there was 2 different procedures, one a vertebroplasty and one a simulated one, did someone from one group or the other want to switch to the other group. So that would be called a crossover group. So 51% of the control group at that time decided to switch to the other treatment, and 13% of the vertebroplasty group decided to switch over, thinking that there was another procedure. Obviously, it was a fake procedure, but that was significant. So, maybe that's something to be said here. At 3 months, these patients crossed over to find relief. Maybe they were more painful in the non-vertebroplasty group. But the conclusion of the study basically points to there are improvements in pain and pain-related disability associated with osteoporotic compression fractures in patients treated with vertebroplasty, but they were very similar to the improvements in a control group. So we're still not sure if vertebroplasties are really clinically indicated, and there's some other studies that back this up as well. The lumbar spine. Surgical procedures and postoperative considerations. We'll talk about decompression and lumbar fusion. So, let's get into decompression first, shall we? This is a hot button topic for me. So, surgical intervention or indications and considerations. Just do a little background work, right? Intervertebral disc cushion and tether the vertebrae, providing both flexibility and stability to the spine. Degeneration or pathological conditions can cause separations of the annulus and the nucleus of the disc, such that a sufficient load can cause nuclear fragments to enter and impinge neural components, whether that's the nerve root or the spinal cord itself. Lumbar disc herniations may occur with little or no trauma. Okay, that should be a little red flag for you, although patients frequently report a bending or twisting motion as the mechanism of injury. So when we talk about little or no trauma, how many times have you guys, and maybe you've done it to yourself, right, or heard of people, they go into their living room and they're cleaning their house and they go to pick up a pillow off the floor and they, quote, throw their back out, right? You think the load of the pillow is what threw their back out? Probably not, right? Probably poor movement mechanics, poor muscle activation, poor motor control, all these things, not the load of the tissue. Just, really think about it. Little or no trauma, a lot of times are the mechanism of injury. Now, common mechanisms of injury of disc herniations are known to be falls, motor vehicle accidents, repetitive heavy lifting. I guess that means I'm in trouble. Sports injuries. Really, you got to think, if someone injures their back, we got to think about it this way. They could very well have had a disc herniation prior to any of these events. But if you fall from a height or you get in a motor vehicle accident, right, you're going to be put through imaging. And the imaging is going to reveal something, right? It's either going to reveal that you have a disc herniation or not. Now, if there is one present, how do we know that that caused the issue? Now, clinically speaking, we can try to distinguish if a disc herniation is causing radicular type pain because it's compressing the nerve root. Then we could have a suspicion that maybe this occurred due to this traumatic event. But a lot of times, there are already present disc herniations that are asymptomatic, and I bet at least half the class has this right now. So this is something that you need to educate your patients on. That disc, a quote-unquote bulging disc is normal, but in the presence of pain and radicular symptoms, that's not normal. So maybe surgery is indicated, but really you need to give physical therapy a shot first, and you'll see why in a second. So whenever I hear this, I always think of this little emoji. So diagnosis, excuse me, MRI confirms impingement on neural structures. Patient has some element of low back pain with radicular symptoms. They may also have weakness or sensory changes down dermatomal or myotomal patterns. They might also have changes in reflexia and in the presence of very severe compression, like something like cauda equina. They may have saddle paresthesias or urinary retention, things like that. So those are big red flags, of course, and that's why we go over all those. Management, it is important to understand that most patients with symptomatic herniated lumbar disc will get better over time. So what does the research say? Weber et al., this is kind of a flagship study that was done several years ago. 60% of patients with complaints of sciatica improved over time with no surgical intervention. There was no difference found in operative versus non-operative group at 4 years or at 10 years. So long term, no difference is found. The main lumbar spine study, 1 year follow-up, this is patients who had lumbar decompression versus not. 71% of operative patients found relief of leg symptoms. 43% of non-op patients found relief. So you may think that non-op percentage is low, but I would be really upset if I had to get surgery and they only said that 71% of patients get better at 1 year. So, what's worse? I would rather try to get into the 43% and not have surgery than be one of the 3 out of 10 people in the operative group that doesn't get relief. So you can always get surgery later, so I would try non-op first, of course. 5 years, 70% of the operative patients reported improvement, and then 56% of the non-op reported improvement. So although it may take some time, right, you still get relief. You still should try non-operative for quite some time unless it's just debilitating. And then another study by Brox et al., 4-year follow-up, long-term improvement was not better after instrumented transpedicular fusion compared with cognitive intervention and exercise for those with chronic low back pain. So this would be someone with chronic arthritis. They looked at 2 groups. 4 years went by. The fusion group and the cognitive therapy / exercise therapy had similar results. The list of these studies go on and on and on, and a lot of these national bodies that recommend clinical practice guidelines and stuff are starting to say there's no sufficient evidence for lumbar spine decompression in mild and moderate cases. Severe cases, it's a different story. Okay, but mild and moderate cases typically with time can improve without the use of surgery. Exercise is a huge thing. So now I'd love for you guys to pause this and click on the link at the top right, which is, well, you probably can't click on it because this is going to be a video. Same goes for the surgical videos. You might probably have to type those in. So I just thought of that. But if you click on that, you will see Steve Kerr, the basketball coach for, who is it? The, Steph Curry's team. I can't forget at this time. Shoot. I'm not a big basketball fan. He has had back surgery. He talks about his challenges with that. So big advocate for rehab. So there's my face again. Spine surgery is so questioned at this time. There's actually a diagnosis called failed back surgery syndrome. And if that doesn't get your ears, perked up, I don't know what will. If you have a patient that's just hell-bent on getting surgery, you got to go over this stuff with them because you can save them a lot of time, a lot of money, and a lot of pain, a lot of anguish if you really try to help them non-operatively. This condition is characterized by chronic pain following back surgeries. Common symptoms associated with FBS include diffuse, dull, and aching pain involving the back or legs. Abnormal sensitivity may include sharp pricking and stabbing pain in the extremities. The term post-laminectomy syndrome is used by some doctors to indicate the same condition as failed back syndrome. Unfortunately, these patients may think that another surgery may be the only option. Now, I would argue that physical therapy, exercise, manual therapy, dry needling, cognitive therapy, Eastern European East Asia therapies, acupuncture, deep tissue massage, cupping, all these things you need to try first before you continue with back surgery. And I hate to say this, but I think cognitive therapy may be the best thing for these patients because they're in chronic pain. They need some severe pain management. We can help a little bit with that, but you want to make sure that they're getting to the right people and avoiding surgery at all costs if they can. So in severe cases, previously mentioned radiculopathy, myelopathy, those sorts of things, lumbar decompression can be indicated. Postoperative considerations, it's important to know the pre-surgical diagnosis, so those ectomies and otomies. Early therapy emphasis on spine stabilization, attention to position and weight-bearing activities, tailoring exercises accordingly, attention to incision and possible use of modalities, frequent neurological checks, work on neuromobility. You also want to work on active range of motion exercises for the spine. They must be done using disc precautions. So we're trying not to small movements, moving into increased range of extremity movements, and then decrease your trunk support by doing things like putting them on unstable surfaces. It is important to initiate cardiovascular training early to help build and restore fatigue resistance. Office level work is permitted within 2 weeks, providing posturing and self-correction of posturing and self-care techniques are adhered to. So this is just another slide talking about lumbar decompression rehab, and it talks about our level 1 spine stabilization program, which is also called the Watkins protocol, and that's going to be on the next one. Walking is a big thing early on. You're going to obviously strengthen what is weak and stretch what is tight, as long as you're not putting excess stress onto the spine when you do it. Here is the Core Institute's postoperative therapy lumbar spine protocol. This says for a lumbar fusion. You can do this for a lumbar fusion or for a lumbar decompression. The decompression will be able to do this more quickly than the fusion typically. So if you pause it here, you get a good idea of the exercise and then the 5 phases that you can progress them through. Just to move this so you can see at the bottom what that says. There you go. So now we'll talk about lumbar fusion. Indications for this are spondylosis, so severe arthritis, spondylolisthesis. And I put the 2 asterisks by this because really this is a lumbar fusion helps with this probably the most, at least in my clinical experience. Lumbar radiculopathy can be another reason. So the procedure is similar in other areas of the spine. Decompression is performed to relieve stress or stenosis on the affected spinal cord and or nerve root. The spine is reinforced with metal rods, plate screws to provide stability to previously unstable spinal segments. This is what it looks like, and we look from left to right. You can see that that is probably a L3, L4, L5 spinal fusion on the left. So we call that a multi-level fusion. And then the pictures in the middle, the grayscale pictures, you can see the spondylolisthesis. L4 is riding forward on L5. That would probably be considered a grade 2, which would encompass 50% of the vertebral body below it. So L4 is a 50% grade 2 spondylolisthesis on L5. And then you can see postoperatively how they've essentially pulled back L4 into a more anatomically neutral position. So you can see why this surgery may be indicated here, because the spinal cord, if we take my cursor here, runs through this area. So there's a huge kink in it. It's got to make this little right-hand turn, which I'm not used to. So if they can pull that back, the spinal cord flows much more smoothly and you stop getting those neurosymptoms down the leg or weakness or whatever. The incision site typically looks like the patient on the right there. So initial evaluation, you're seeing these patients at 6 weeks post-op. You want to check the incision site. They can have several different types of lumbar fusion incision sites. There can be an anterior one, which is called an anterior lumbar interbody fusion. You'll see that as ALIF. A posterior, which is PLIF, or posterior lumbar fusion. And then, of course, there's a lateral fusion as well. And I've provided videos of all these. Postoperative considerations, the big one here is no bending, no lifting, no twisting for 12 weeks. The clearance to do this is usually made by the PT and surgeon. It can last longer than 12 weeks. The thing here is that patients will come in and they will do this stuff. They will bend, they will lift things, they will twist. They'll tell you how they were in the garden for 3 hours the other day and they had to pick up pots and all this, and you're like, what are you doing? So use that as a point of patient education. Don't get too upset. Really, a little bit of these things is probably okay in isolation, but when people are doing combined motions, like they're going and doing laundry and they're lifting up their laundry basket from the floor all the way up onto the laundry machine or something like that, they're doing that repetitively, that is when this bending, lifting, and twisting really becomes a problem. So don't kill them for doing a little bit of this in isolation. You might even see it in your gym. Just try to reinforce that. So lumbar fusion. When can I get back to driving? It is possible once the patient is off any narcotic meds and once the patient is ambulating free of assistive drugs. And the legs are strong, of course. They have to have good motor control and coordination of their legs too. So I've even done seated drills where I have patients do like cone taps with their leg to see if their motor control is back strong enough to even think about driving. What about sex? Well, they can't have any segmental motion, so nothing, out of the ordinary in terms of intercourse. You want to keep neutral positions and allow the partner to perform more of the activity. It may start when the wound is healed. So usually around 2 weeks, that wound is healed, and as long as you're having a neutral spine during this activity, there's nothing that says you can't, but you just want to make sure that you educate your patient, and they will ask you about this. You want to educate your patient proper position. So try to be professional with this. This is a huge part of people's lives, right? So just educate them on the spinal precautions and try to give them ideas. Smoking, review with the patient to avoid smoking at all costs, and all other uses of nicotine really slows down healing time. The patients that have seen that they've ruined their lumbar fusion or their cervical fusion are always smokers. They have poor bone health, they have poor healing, they continue to smoke, and they end up ruining their screws seem to come loose, and they ruin their issues. So no smoking. How about lifting? Lifting 10 pounds maximum at 0 to 8 weeks. Healing should be another one. For reference, most healthy fusion cases do not completely fuse until 6 months. And then should they wear a brace? It's a surgeon's preference. I would say no. Some wear TLSO for 2 weeks post-op and then lumbar brace for 4 weeks. I think they're really getting away from that. I haven't been inpatient in the hospital in a while, and that's usually where I would see and help patients put on a TLSO brace. But at this time, I think they're kind of getting away from that and letting patients' muscles do more of the work. So about rehab, it's important. There's an important inpatient component to this rehabilitation. You really have to teach them bed mobility, rolling, walking, safety, balance, the list goes on and on, maintaining their spinal precautions, no bending, lifting, twisting. So huge importance in inpatient rehab for this, and they're typically there from 0 to 5 days. Rehab timeline, you're going to start outpatient PT about 6 weeks. From 6 to 12 weeks, there's deep core stability training, teaching them more about neutral spine, hip strengthening, gait training, functional training. And then after 3 months, if the fusion is healing well based on radiographic evidence, the restrictions of no bending, lifting, twisting is lifted, but then you progress them out of that. So it's not just like, hey, free for all, you can go bend, lift, and twist all you want. Really try to build them up and improve their tissue extensibility. Continue working on strengthening in patients' long-term goals at that time. So here, the next 4 slides are all going over what's in your book for lumbar fusion and laminectomy, an interesting rehab program. You'll notice that the postoperative days are mentioned on the underneath of phase 1 there. So this is the inpatient consideration. As we move to phase 2, this would be starting at 6 weeks post-op. This would be going starting at outpatient physical therapy. So you can pause it here. Continue at, this would be phase 3, which starts at 11 or 12 weeks post-op. And then finally a phase 4, which starts at about, I guess that would be 4 months, 5 months post-op, all the way to 1 year. So please review this stuff. I'm not going to take specific bullets and say what phase is this in, okay? But you should get an idea if I say, patient needs to, is going to initiate running, cutting, and jumping and lumbar fusion surgery. approximately what week is that appropriate. Is it appropriate, week 0 to 1, weeks 8 to 10, weeks 20 to 24, etc. So I want you guys to think about it in that way rather than trying to memorize these slides. Just really, we're going to kind of keep this like street smart a little bit instead of book smart, okay? Surgical videos, again, you guys will probably have to pause this and type these out, so I apologize for that, but I want you guys to look at the lumbar decompression and then the 3 types of lumbar fusion surgeries, and you guys can do that now. Other procedures is the last slide, so thanks for making it through. We haven't gone over this, but trauma can cause a lot of crazy things to happen. You just look at these x-rays and all these things that have been fused or stabilized. ORIFs all over the place, right? Clavicle, we got ribs, we got, scapula, you got your acetabular, not your acetabular, the rim of your pelvis has been stabilized. It's just some crazy stuff happens. So, there's no protocols. You just have to have good communication with the referring surgeon. So I want to thank you guys so much again for the last 2 weeks. I've had a lot of good time with my family. You guys, I'm sure, have had a lot of great time studying, and I really hope that everything went well for you. I will see you in class on Wednesday. We will be doing presentations at that time. So just a reminder, 15-minute presentations. There's no papers or anything associated with that. So just do a presentation. I want a copy of it. And then the week after that, so a week from this coming Wednesday, I believe it would be the 24th of May, that's going to be your final exam. It's going to be all multiple choice, probably be 50 questions again. But it's going to be cumulative on all 3 sections, upper, lower, and spine. You guys will do great on it. You just have to put in a little bit of studying, okay? So just a review from test 2, really obvious who put in the time studying, really obvious who didn't, and your scores reflected that. So you guys will be just fine. You just got to review the material, all right? So you can always email me at any time, and I will see you guys on Wednesday. Thanks again so much.